Hello everyone. So we're going to be talking about palliative care. And palliative care, we will discuss restorative health care, end-of-life care, as well as bereavement that follows death. So with palliative care, the needs are increasing. That's due to demographic changes. Patients, especially women, are living longer, and plus we have that large baby boomer population, and plus we have better medicine, pharmacology, we have more procedures. So with palliative care, essentially you are improving the patient's quality of life, not the quantity. And it also alleviates the burden of care, and it helps the patient and the family with the grieving process. So with hospice care, the program focuses on symptom management, advanced care planning, spiritual care, family support, palliative rather than curative care, and quality rather than quantity of life. So with hospice, palliative care allows for curative and palliative treatment simultaneously. Hospice often requires a physician's certification that life expectancy is 6 months or less, but hospice can extend over a 6-month period as well. Because if you have a patient who has cancer, their death may occur to short duration, or maybe the patient could live up to 9 months. Hospice care, it's often underutilized, but now hospice care, patients can receive it not only in their home, they can receive it in the hospitals as well as long-term care centers. Patients do not have to be actively dying in order for hospice to be consulted. Typically, the most common diagnoses for a consult for a hospice patient is cancer. Hospice care, it's 24 hours, 7 days a week. If the patient is living at home, obviously someone has to be there to care for them. Hospice care has 2 criteria. The patient must desire the services and agree in writing that only hospice care can be used to treat their illness. The patient can withdraw from the program at any time. Patients must be eligible for services. Like I said, typically less than 6 months to live. After this, the physician needs to recertify that the patient needs the hospice care if they have not passed. And of course, you will have patients who may have hospice, but then their health turns around, and patients can be discharged from hospice, or physicians can terminate it. So with death, anytime you have a patient who has died, you want to make sure that you document that there are no vital signs. You need to notify the physician as well as other consults who may be seeing the patient in the hospital. Typically, the ward secretary can do that, but you need to call the doctor because obviously the patient died because they need to be released then to the funeral home. So with end-of-life care, this refers to the patient's final phase of the patient's illness when death is imminent. Often as a healthcare provider, you will be often asked, well, how long is my mother or father going to live? And obviously, you know, we don't know. We don't know how long someone's going to live, but, you know, things that you can do during your physical exam, you know, look, is the patient modeled? Has their blood pressure dropped? Is their pulse, is it weak? So those are things that can help to determine possibly if death is imminent. You could have patients who have apnea, Cheyne-Stokes breathing, and they can go through this for 2 to 3 days. So with the respiratory system, often the patient has irregular breathing that gradually slows. So breath sounds may become wet, noisy, both audibly on auscultation as well. Noisy, wet sounding respirations, termed the death rattle, or terminal secretions, are caused by mouth breathing and accumulation of mucus in the airways. Cheyne-Stokes respirations, it's a breathing pattern characterized by alternating periods of apnea and deep rapid breathing. Hearing and touch. Hearing is usually the last sense to disappear, so you need to encourage family and friends to talk to the patient or hold the phone to the patient's ear if the family cannot be there. Often maybe families, they live far away, maybe they can't make it in to see their mother or father. Decreased sensation, that's due to circulatory alterations in the lower extremities. Taste, smell, and sight. So the patient's vision is often blurred. Their eyelids may remain half open. There's a decrease in sense of taste and smell as well. With the integumentary system, modeling of the hands, feet, and arms and legs. So modeling looks very faint, like purple. It has kind of a leopard pattern to it. It could be like purplish spots, and then you have that white pale skin. Cold, clammy skin, the skin cools first on the lower extremities, then the upper extremities, and then finally the torso, unless the patient has a fever that's present. If the patient has a fever, they're often very diaphoretic, and you need to change their bed sheets frequently. Look at their nail beds, the lips. Is the patient becoming cyanotic? The urinary system, kidney function, and sphincter control diminished. There's a gradual decrease in urine output. You want to make sure that you're checking the patient every 2 hours for incontinence, turning the patient side to side. If you have a patient who is not taking anything in by mouth, they have no IV fluids, nurses may become concerned, well, I have to get a straight cath order to straight cath my patient. Well, that's not always true. If you're not taking anything in by mouth, you're not receiving IV fluids. Okay, so check the patient's bladder. Palpate it. Is it firm? Is it distended? You know, if the patient is restless, obviously if it's firm and distended, then you would want to straight cath them. But if that bladder is not firm or distended, there's no reason to straight cath that patient. They're not taking anything in. Opioids, with the gastrointestinal system, obviously they're going to slow peristalsis. Often patients who are lethargic are nothing by mouth. So you can give them Roxanol, which is also, it's liquid morphine. You can give them anywhere from 5 to 20 milligrams. They can get 20 milligrams every hour as needed. Just depends upon if the patient is in distress. And this is given sublingual, under the tongue. So the patient, you may notice their abdomen is distended. There could be quite an accumulation of gas due to slowed peristalsis. Often patients will have a bowel movement prior to death, which is imminent. With the musculoskeletal system, there's a loss of facial muscle tone. The patient may not be able, they may not have a gag reflex, talking is difficult, swallowing, that can become difficult for the patient. So then you may want to consider honey or nectar thickened liquids. You need to make sure that you're providing good mouth care as well. Cardiovascular, you will notice that heart rate is increased and then later it slows, that pulse weakens, blood pressure decreases, there's delayed absorption of IM and sub-Q drugs. That's due to the decreased blood flow. And typically when I go in and I assess a dying patient, obviously I would do a good head-to-toe assessment, but typically if someone's dying, I check on the patient every 2 hours. I will look at the lower extremities. Is there mottling? Are they cold and clammy? Then I'll check the upper extremities to see if they're cold and clammy as well. I will feel the pulse to see if it's becoming weaker. I don't necessarily check a blood pressure every 2 hours. Obviously that you're pumping up that cuff, that can cause some distress to the patient, maybe uncomfortable. And then also too, typically I always go in, I have my nursing assistant come in with me because, you know, you want to make sure that you're turning the patient, they're not incontinent. You know, you want the patient to look nice. You know, you want that patient to die with dignity. And of course, at the end of life care, the patient and family, well, especially at the family, they may be overwhelmed, fearful, they may feel powerless. Families, they can become upset and angry, and often they do take this out on the nursing staff. Maybe they're mad at themselves because, you know, mom or dad's dying and, you know, they didn't spend much time with them, or they're angry at the fact that they're dying. Bereavement, this is the period of time following the death of a loved one. Grief, it's a normal process of reacting to loss. Psychological responses can include anger, guilt, depression, anxiety, sadness. Physiologic reactions include sleeping problems, changes in appetite, physical problems, as well as illness. Another thing with hospice is you may notice they give drugs a little bit differently. Often they'll give Haldol for nausea, and as well, you know, yes, they'll do Roxanol sublingual, but also they may give medications rectally, pills, such as maybe like an Ativan, that can be as a pill given rectally. The 5 stages of grief, it's the Kubler-Ross model. Denial, that can last minutes to months. Anger, they're angry at the person who inflicted the hurt. They often feel mad at the world, or they're mad at themselves. Bargaining, this often occurs for some time after the patient has died. Depression, Maybe the patient feels numb, anger, sudden sadness. And then, of course, acceptance. That's the reality of the loss. It results in a calmer phase. Anticipatory grief. Caregivers of patients with chronic illness often begin to grieve long before the actual death. Skipping over to dysfunctional grief. This is an extended and intense mourning. It often occurs for parents who have lost their children. They are in denial. This lasts longer than greater than 6 months. Parents often talk of their children like they're still alive. They often lash out at other family members. Grief supports, grief counseling. This facilitates discussion of feelings, and it cultivates an environment for open expression of all feelings: anger, fear, guilt. Spiritual needs, I always will ask the patient, the family members, if they would like to see the priest. And if they don't, I just go ahead with what the family and the patient wishes. Cultural competent care. So some groups, Hispanics, Latinos, they may express their feelings and emotions more easily. With kinships, they're very strong in Hispanic cultures. Both immediate and extended family provides support, and expressions of feelings is encouraged and accepted. With legal and ethical issues, if you have a patient who's dying, you want to find out if they are a organ or tissue donor. Do they have advance directives? Do they want to continue to be a full code or do not resuscitate? Do they want to be put on a ventilator? Do they want a tube feed? But the first thing that you have to determine if the patient has capacity. So if they're Norina times 3, they can still make decisions for themselves. If the patient wants to be a DNR, you need to call the physician and get an order. Sometimes families, maybe their children won't agree with that, but you have to abide by the patient's wishes. If that patient can no longer make decisions for themselves, then it is up to the medical power of attorney or possibly next of kin. So often you may have an elderly patient who's dying, and maybe there's 3 or 4 siblings. One is the medical power of attorney who can make the decisions, whereas the other siblings may not agree with the medical power of attorney. And there's often a lot of conflict, but again, you have to go with what the medical power of attorney decides. If you do have a patient who has capacity, they're with it, looks like death is imminent, find out what they want. If they want to be a DNR, make sure that you call the doctor immediately. You don't want to go to social services and say, hey, my patient, they want advance directives now. They want to be a DNR. If that patient's going to die suddenly, you need to get the physician on the phone to get that DNR order. Organ and tissue donations. This can be specified on donor cards. In some states, driver's license. It's handled by various agencies that differ by state and community. Often patients have to be sent down to the morgue more quickly if they're an organ donor. Advance directives. So essentially for advanced directives, typically social services, if the patient wants these in the hospital, you consult social services goes and talks to the patient, and then often the social service worker needs two witnesses to sign, and you may be asked to do that. And essentially all you're doing is witnessing that that is the patient's signature. Resuscitation. Like I said, you want to make sure you know the patient's wishes. Often you do have patients that are full codes. They want everything done. And a lot of times you may have patients where death is imminent. You have medical power of attorney. They want everything done. They want a tube feed. You know, you have to abide by that. Patients, maybe if it's a COPD, maybe they want CPR, but they don't want to be intubated, because end-stage COPD, they could end up on that ventilator for the rest of their life. Comfort care measures and pain control, symptom management, those are often what is the hospice end of life. So always make sure that you are informed of the patient's wishes. Euthanasia, obviously this is against the law. A lot of times I have had patients' families where the patient's dying, and maybe you're giving the patient Roxanol sublingual, and the patient maybe only need it every 4 hours. Well, the patient's family might say, well, I want this every hour. Well, you know, I explained to them that, you know, this is the way it's ordered. Roxanol is ordered for pain, restlessness, increased respirations. If I don't witness that, then I'm not going to give the patient the medication. You know, because often families will be like, well, can't you just give them a bigger dose so it ends this? No, you can't do that. So with assessment, at least every 8 hours in the inpatient setting, and every 2 hours, like I said, I would check the patient's pulses. Are the extremities warm or cool? Is there any mottling? I'd count the respiratory rate. I would check the pulse to see if it's weakening. Are they using their accessory muscles to breathe? Always document if you're giving a PRN medication. Document whether, you know, let's say for a patient you have that's restless, and you give them the Roxanol, maybe 20 minutes later you go in the room. Are they grimacing? Are they guarding? Are they still restless? If they are, maybe that dose of Roxanol needs to be increased, or you need to call the physician and get something for breakthrough pain. Typically, in a long-term care facility, they often give the Roxanol. They give atropine for that death rattle, as well as Ativan. Also with assessment, look at the patient's level of consciousness. Is there any pupil response? Is there a change in vital signs? Change in the temperature? Is the patient's respirations increasing? Do they have bowel sounds? A lot of times, the patient may not have a family member. I've had a lot of patients who their family members, they don't come and see them because they're angry. I hate to see patients die alone. If that's the case, I try to spend a lot of time with them, maybe just sitting by the bedside and holding their hand. Death is scary, and so maybe that patient could be very agitated, very fearful, and just having the presence of someone at the bedside can relieve that. And I'm skipping over multiple slides here. Other things that you can do, you'll have patients who experience air hunger. You can give, like I said, opioids, Roxanol, bronchodilators. Maybe they need an aerosol treatment as well. You can also apply oxygen. Maybe the mask would be more beneficial as opposed to a nasal cannula. If you have a patient who's a mouth breather, often when I do end-of-life care, I'll just put the oxygen in the patient's mouth, that nasal cannula. Other things that you do in the hospital, you can ask dietary to bring up a courtesy tray. If you have a lot of family members, friends, it often has coffee, tea, snacks for them. Postmortem care, obviously, this is when you're cleaning the patient. A lot of times you'll send dentures, glasses, maybe a rosary, and often that goes to the funeral home. Also, too, another thing you might want to ask about, a lot of times, if, let's say, for instance, you have a patient who coded, sometimes physicians will order an autopsy. It could be just of the chest, it could include the brain. Often, if the physician orders it, it's covered by insurance. If a family wants it, they may be responsible for paying for that autopsy. So I think that's pretty much the end of our lecture. So I will be uploading this, and you guys can watch it soon, and I will work on your review sheet. Thanks.